a great pleasure for me that I have been given this opportunity to speak today. Today's topic is ACS in women, how they differ. Now, if you look at the occurrence, 45 to 64 years of age, 1 in 9 women develop symptoms of some form of cardiovascular disease. And after 65, this ratio climbs to 1 in 3. Although there has been a reduction in the death rate from coronary heart disease since 1980s, the 2013 data shows that 22% of the all-cause mortality in women is due to coronary heart disease. Women in coronary heart disease are generally 10 years older than men, and at the time of presentation, they carry a greater burden of risk factors. Now, atherosclerosis is quite common etiology. However, non-obstructive coronary artery disease in females is as well much more common compared to males. INOCA, that is and as well as MINOCA, that is the ischemia as well as myocardial infarction with non-obstructive coronary artery disease is twice as common as males. Women account for about 90% of the Takotsubo cardiomyopathy. Now, this condition basically mimics ACS, but it actually means myocardial injury. Now, incidence of ACS in pregnancy is 6.2 per 1 lakh. The risk of MI in pregnancy increases 3 to 4-fold, and mostly in the third trimester to 6 weeks postpartum. Spontaneous coronary artery dissection is also quite common. Now, the classic syndrome of left-sided chest pain radiating to the jaw is as same as the male, but the initial registry showed that the chances of having chest pain was much less compared to men. But the present trials, they are showing that Vargo trial as well as the high-stakes trial have shown that the reporting of chest pain doesn't differ. But the non-specific symptoms, that is on presentation having dyspnea, nausea, syncope, fatigue, etc., these 2 or 3 symptoms often come forward before the classical chest pain. The Vargo trial moreover showed that there is a delay in seeking care for the woman, as well as recognition by the healthcare system is also delayed, and there is a delay in starting the treatment of STEMI as well as transfer for PCI. Now, I'm not going to the classical risk factors. However, the non-traditional risk factors like depression, mental stress, low socioeconomic status, these are very important, as well as limited education is very important and relevant in our country. If you look at the pathophysiological difference, plaque erosion is much more common in women compared to men, where plaque rupture is common, and PCWB is increase in STEMI. This is independent of the age, hypertension, and infarct size, and may be due to the gender effect. Females have a less complex coronary artery disease, less burden of the disease compared to males, and relatively smaller coronary arteries. INOCA, that is the non-obstructive coronary artery disease, is accounted for mostly by the microvascular dysfunction or coronary reactivity or plaque erosion. And the Y study has shown that these are not benign conditions, and they may present at 10 years with higher mortality compared to that of normal coronaries. The INOCA are 4 times more likely to be admitted, the females with ACS at 6 months. The myocardial infarction with non-obstructive coronary artery disease is 5 to 6% of the all AMI, and women are having twice the chance of having a normal CAG and of non-obstructive coronary artery disease. And again, here the etiologies are plaque erosion, rupture, vasospasm, microvascular dysfunction, and spontaneous coronary artery dissection. Now, Takotsubo cardiomyopathy, which I was talking about, it mimics ACS, and 4% of the presumed ACS found to be having Takotsubo cardiomyopathy. And 90% of them are females, and postmenopausal ladies are particularly affected. ACE inhibitors could be helpful in this. In pregnancy, coronary artery dissection is the topmost etiology. Next is the atherosclerosis, and then comes the normal coronaries or the normal and the arterial spasms. Regarding SLE, between 34 to 44 years of age, 54 more chances of having AMI. And it was found in an ultrasound study, it found that 28% of the patients had progressive atherosclerosis over the carotids over 34 months of period of follow-up. So, if we look at the management difference, the Sweetheart study, it has shown that guideline-directed medical therapy was lesser used in the females. The action registry has shown that PCI event was also lesser in females, was done lesser in females compared to that of males. But despite greater delays in reperfusion and post-MIEF, similar infarct size compared to males, there was a higher mortality and heart failure hospitalization at 1 year. So this was not explained with the usual parameters. Maybe the accumulating risk factors with age could be a contributing factor. Moreover, incomplete revascularization is also more common in females despite lower burden of this disease, and here the syntax score often remains more than 8. Now regarding fibrinolysis and PCI, definitely primary PCI fares better over fibrinolysis, and fibrinolysis in menstruating female, we have a limited data and shouldn't be excluded. But the results of fibrinolysis are as comparable to that of males. Again here, another study, the Cadillac study also showed that post-primary PCI, the results, the mortality as well as the major adverse cardiovascular events were worse in females compared to males. And this could again be due to smaller body size, smaller coronaries and other risk factors. There are a number of differences in complications, like free wall rupture is more common in females. Increased chances of ischemic stroke as well as the cardiogenic shock, the mortality was more in females. But the sudden cardiac death was lesser compared to male. Now in pregnancy, 2 or 3 things to be kept in mind. One is fibrinolytic therapy, a relative contraindication. AC inhibitors, ARB and statins are not indicated. The mainstay of therapy are heparin, aspirin, beta blockers and nitrates. CABG in women, again 32% more mortality compared to males, and higher perioperative and morbidity and mortality. And there were 30 to 90 days readmission after CABG. So it could again be due to smaller artery size, lesser body weight, ASCVD risk factors as well as age. So the take-home message could be conventional risk factors with plaque erosion is common in females. Non-obstructive coronary artery disease like INOCA and MINOCA are commoner in females twice as that of the males. Higher mortality is mostly related to the lesser use of guideline-directed medical therapy and PCI as well as delay in the management. There is increased chance of ACS during pregnancy as well as SLE. These are the common, SLE is quite a common clinical situation. Post-PCI and CABG, there is increased mortality, and that could be due to increased risk factors, smaller coronary arteries, as well as body weight. Menopause is an ACS risk factor without similar male equivalent. Complete revascularization after STEMI is important for women. Variety of vascular dysfunctions and psychosocial aspects are to be understood in a better way to give a greater benefit. And older age, disproportionate burden of comorbidities and delay in seeking care are the utmost importance. Thank you.